So I need to give you a caveat. I have All right. Hello, this is Yuko, and this is lecture number 4. So we're going to cover tonight anxiety disorders, schizophrenia, and also the client's response to illness. So let's take a look at anxiety. I think we all can relate to the picture here on the front because we've all felt some form of anxiety throughout our lives. So I need to give you a caveat. I have gone through and fixed these slides 4 times and they still keep cutting off here at the edge. I do apologize for it. Just bear with me, please. So here are your objectives. So the introduction, anxiety provides motivation, right? It can be used constructively because at a low level, it can also make you more ready to be able to learn. It's one of the most basic emotions. It can be dysfunctional, but it's because we're using that as a defense against an anxiety. So as our level of anxiety decreases, though, our level of dysfunctionality also decreases in proportion. So anxiety is an emotional process whereupon fear is cognitive. All right, so there's a general adaptation syndrome, which says that we go into an alarm reaction stage, and that's when we're getting ready for the defense, right? Do we fight or flight? The resistance stage is where now blood is being shunted to the important organs in our body, and then adrenaline shoots up and we're like ready to go. The exhaustion stage follows after the depletion of the adrenaline, and we're left just exhausted. We feel and look like a wet, limp washcloth. So it's more common in women than it is men. Any idea why that might be? Because usually, not only hormonal, but usually women tend to try to do it all, right? We have so much more that oftentimes we take on. So it could be considered abnormal if it's blown out of proportion and it interferes with anything socially and occupationally. So the stages, the mild stage, there's some increased sensory stimulation. You know, you're more heightened in your alertness, you're looking around, you can hear better, you know, and you just kind of feel like, you know, I just kind of need to be a little worried here. Moderate, you definitely know something is wrong, okay, and you begin to feel nervous and possibly agitated. You have difficulty concentrating because you're trying to focus on what it is that's wrong, all right, but you can still be redirected. If it's severe, you can't think straight, you can't reason, muscles tighten, your vital signs shoot up, you become restless, you become irritable and very, very angry, which then can lead into panic. In that mode, you're in fight or flight. Okay, you either fight, flight, or freeze. Your vital signs increase, you develop complete tunnel vision. You cannot hear things that people are saying to you. If you're talking to someone who is in a panic, don't bother because they're not going to hear. Whatever you do, do not ever touch somebody who's in a panic. Okay, so panic disorders characterized by repeat panic attacks. In between those panic attacks, the individual lives in a heightened state of anxiety because they're afraid when the next panic attack is going to occur. And what if it's out when I'm out in public? Or what if it's when I'm in school and I don't have anybody who can help me, or I make a fool of myself? The fortunate thing is that it's self-limiting. It's about 10 minutes, but to the individual who's experiencing it, it feels like a lifetime. So there's a thing called agoraphobia, where there's a fear of public places or crowds. Just make sure that the individual knows that they're safe. Try to stay with them so that they can see you, get them to safety, someplace where they're going to feel safe. All right, generalized anxiety disorder. I think we all kind of know somebody who's always chronically, unrealistically, always anxious and always worrying about something. In fact, when they don't have something to worry about, they worry because they don't have something to worry about. So, panic and generalized anxiety disorders, the psychodynamic theory by good old Sigmund Freud, or as I call him, Captain Obvious, says it's an overuse or ineffective use of our ego defense mechanisms that results in a maladaptive response to anxiety. So, cognitively, we have faulty, distorted, or counterproductive thinking. All right. So, what we need to do in cognitive therapy is we bring the patient out of the past, out of the future, and bring them into the here and now. And we show them how their emotions affect their actions, and their actions affect their emotions. And we need them to be able to take responsibility for both. All right, so we can use the Hamilton Rating Scale for anxiety as an assessment. We can, when we talk with them, please use short, simple, easy to understand sentences. In fact, I cut down usually to one word, like sit, drink. All right, don't give them overcomplicated instructions because they're not going to hear it and they're not going to be able to focus on what it is you're saying. You want to get that individual's anxiety level lowered to moderate or mild before you move forward. Speak to them in a low, calm, and soothing voice. When they are in a panic, safety is a primary concern. Again, do not touch them. We can use short-term anxiolytics. However, remember that a lot of times they tend to be very addictive. So, we're looking at the combination of medications and therapy, medications including antidepressants, using cognitive behavioral therapy, doing positive reframing where we turn negative message into positive ones. We prevent them from catastrophizing things and having them look at things in a more realistic, calmer way. And also, maybe they need some assertiveness training so they can stand up for themselves. So, benzos. What you need to know is they can cause paradoxical excitement. That can lead to increased anxiety, insomnia, aggression, nightmares. If they have been on benzos for a long period of time, they must be tapered down slowly. Otherwise, they're going to have grand mal seizures. They increase fall risk in the elderly. They decrease fear, so they're very, very beneficial. Flumazenil or Annexate is the antidote for benzodiazepine overdose. It prevents the benzo from binding with receptors, and it acts in 1 to 2 minutes. So, benzodiazepines, Klonopin or clonazepam, Valium or diazepam, Librium or chlordiazepoxide. You'll also recognize that from the alcohol detox, Transine or clorazepate, Ativan or lorazepam, also used for alcohol detox, binds with the benzo receptors at GABA, rapid onset, but they tend to be more sedating than the other benzos. Xanax or alprazolam binds with GABA, also less sedating than the other benzos, however, has a real long half-life of 12 hours. Buspar or buspirone is one of my favorites because it is a non-benzo, but it takes anywhere from, I believe, 3 to 8 weeks before it works. It's really good for the elderly. It helps take the edge off of their anxiety without overly sedating them and increase their fall risk. Vistaril or hydroxyzine is an antiemetic, blocks histamine receptors. It's not quite as sedating as the benzos. Benadryl or diphenhydramine blocks the histamine receptors, however, has a hangover effect and drowsiness. Be very careful in giving this medication to elders over 65, as it can increase fall risk and also cause confusion. All right, so what can we do as far as other medications? We can give selective serotonin reuptake inhibitors, or SSRIs. They're the first-line medications specifically for depression. Selective serotonin norepinephrine Reuptake inhibitors, or SNRIs are also first-line treatment for depression. Tricyclic antidepressants, second or third line. The bad thing about TCAs is that if a patient takes them in an overdose, they tend to accumulate in the myocardium and they cause fatal arrhythmias. Benzodiazepines, we just covered that. Atypical benzos, we just covered that. And we can also give beta blockers, things like propranolol or Inderal. But the problem with that is then you have to watch them for postural hypotension, and you also have to watch them for bradycardia. So let's talk about the SSRIs. Citalopram and escitalopram are both isomers of each other. All right, they're not good to use with people who have seasonal affective disorder or individuals with personality disorders. Fluoxetine, fluvoxamine, paroxetine, and sertraline are all oldies but goodies. All right, dual action SNRIs, also first line medications for depression, the duloxetine and the venlafaxine. All right, we talked about the buspirone, the Buspar, helps to alleviate the anxiety. All right, less sedating, works best if you give it before you try the benzos. All right, phobias are intense, illogical, persistent fear of a specific object or situation. Usually the response is out of proportion to the circumstance. Categories: agoraphobia, specific phobias. Specific phobia categories are natural, blood, which I think all nurses have, right? Situational, animal. The treatment: behavioral therapy, positive reframing, assertiveness training, systematic desensitization. That's where you take somebody and you expose them gradually to whatever it is that they're fearful of. And flooding, which I don't highly recommend. That's basically like throwing somebody in a swimming pool. So obsessive compulsive disorder, the assessment data, they get obsessions and compulsions that are severe enough that they can cause marked distress because it causes significant impairment. The obsessions are unwanted, intrusive ideas, thoughts, or impulses, and the compulsions are the repetitive behaviors or patterns that they have to do, and it's not to provide pleasure or gratification, it is to reduce anxiety. All right? Biochemically, it's because serotonin may be influential. So, post-traumatic stress disorder, also known as PTSD, anybody exposed to any type of traumatic event can develop PTSD. Characteristic symptoms: they get numb, they always have a perpetual state of anxiety, they're always aroused and watching, hypervigilant. Oftentimes they have intrusive nightmares and flashbacks. Prazosin also may be a medication that may help to diminish those nightmares. All right, and that's it for that. Let's move on to the big heavy duty one here, schizophrenia. All right. So here's your lecture objectives. So schizophrenia is derived from the word schizo, which is Greek, which means split, and phren, which means mind. It can be devastating. It affects their ability to function socially, occupationally, and be able to perceive reality accurately. All right, so here's a scan of a gentleman who was initially diagnosed with schizophrenia, and 5 years later, you can see the significant difference in his brain function. So we know that there is a genetic predisposition. There can be biochemical dysfunction, specifically with dopamine, physiological factors such as illness, psychosocial stress. We know that oftentimes precipitating the first psychotic break is some sort of psychological stressor. It can also be caused by substance abuse. Oftentimes they have feelings of anxiety, depression, suicide. They may become ill physically and may develop something that's called polydipsia, where they drink copious amounts of water. And oftentimes they do that so that they wash out the antipsychotic in their system. Diagnosis: peak onset for males, 15 to 25. For females, 25 to 35. About 1% of the population, nearly 3 million people are, will be, or have been diagnosed with schizophrenia. Schizoaffective disorder is a mixture of psychosis and mood symptoms. It's abrupt. It can be as insidious. Diagnosis is usually done because they have positive symptoms of psychosis. That meaning they are usually delusional or they're hallucinating. All right. It causes lengthy hospitalizations, chaos, and I want you to think specifically about the fears that are perpetuated by the media. All right. They're the image of an individual who's schizophrenic is somebody who's unpredictable. They're dangerous. You often see the picture of the gentleman with the long hair. He's very disheveled and unkempt, big, wide open eyes. We do again know that biochemically it's caused by an excess of dopamine-dependent neuronal activity in the brain. Biologically, again, genetic, okay, neurochemical and neuroanatomic factors, immunovirological factors. Whoa, that was a mouthful. All right. And we notice an uptick after influenza epidemics and respiratory ailments. So with this COVID, it'll be real interesting to see whether or not we see an increase in the number of individuals diagnosed with schizophrenia. So the different types. Disorganized schizophrenic is exactly that. They are very, very disorganized. When you talk to them, they don't make a lot of sense. They oftentimes have bizarre behaviors, social interactions impaired. They oftentimes are silly, laughing inappropriately. Catatonic is where they are completely unresponsive. They are total care, and they are usually mute. Paranoid is probably the most common one that we encounter. They can be argumentative, they can be hostile, they can be aggressive. They can be delusional. Schizoaffective, again, that's where they are either manic or depressed, along with psychosis. So basically, the easiest way to say this is that they are schizophrenic with bipolar disorder. All right, so different types. Brief psychotic disorder, less than a month. And then they go back to pre-level functioning. Schizophreniform is when it's been a month, but less than 6 months. Delusional disorder, there's different types. Oftentimes the erotomaniacal type is related to stalking. The grandiose type thinks that they, oftentimes you'll hear them say things like, well, I'm the one who carved the Statue of Liberty, and I'm the person who got Abraham Lincoln elected to office. All right, and then there's also the jealous type. Persecutory type, people are after him. Usually it's the police and the FBI. Somatic type, I have this pain, I have that pain. Substance induced, you only have so many brain cells to burn out. And when you use things like when you are a huffer or you use street drugs and you burn out those brain cells, then yeah, you can get a drug-induced psychosis. All right, so these are different components of schizophrenia. Under content of thought are delusions, which are false personal beliefs. They can be hyper-religious, where they have an excessive obsession with religion or behavior. Under content of thought, again, paranoia. The associative looseness, where they go from one idea to another. Neologisms, if you remember, I spoke about that before, and I was saying that twins often make up their own language that only they understand. Magical thinking, where they believe that their thoughts or behaviors have control over situations or people. Okay, form of thought, concrete thinking, being literal. Okay, and then there's the word salad. It's a bunch of words that sound like they're thrown together. They don't make sense. Clang associations, often rhyming. If any of you have seen the movie Sybil, the mother was standing in the kitchen and she was chopping like a lettuce for salad or something, and she was going, Linner, dinner, spinner, sinner. Okay, they clang, they rhyme. Circumstantiality, You ask them a question and it takes them forever to get to the point. Form of thought, tangentiality, going off on tangents. Mutism, not speaking. Perseveration, there's that word persevere. They stay stuck on the same thing. Perception. Now, when we hallucinate through the five senses, right? So here's what you need to know. Please remember this. When somebody is psychotic or hallucinating, it's because there's a breakdown in their thought processes, not in their sensory perception. Okay? So think about it this way. Because you can see, does that mean you're hallucinating? No, because there's no breakdown in your sensory perception. If there was a breakdown in your sensory perception, you would maybe need glasses, you may be blind, right? But when there's a breakdown in your thought processes, when you see, you're hallucinating, okay? So it's a breakdown in your thought processes, alterations in thought process. Okay, illusions are things that are actually present in the stimuli, but you misinterpret them. Affect is your emotional tone. If it's inappropriate, it's not right, okay, with whatever's going on. Bland or flat sounds, pretty self-explanatory. And somebody who's apathetic loses interest in the environment. Sense of self, that's where they don't know where they end and you begin. Echoalia, they repeat words that are heard. Echopraxia, they repeat movements. All right. Identification and imitation, where they take a form of behavior and they copy it. Depersonalization, a feeling of unreality. Volition, where you do something on your own free will. Emotional ambivalence, where you have opposing emotions, like you love it and you hate it. All right. Impaired in personal functioning in relationship to the external world, autism. They focus inward, okay, and they're living in a fantasy world while they exclude the environment externally. Deterioration in appearance. I call this ADLs, activities of daily living, because they no longer keep themselves up in grooming, self-care activities like changing clothes. And hedonia, inability to experience pleasure. Psychomotor behavior, anergia, A, without nergia, energy. They get waxy flexibility where you can basically mold their arms or legs into any position and they will stay that way for hours. Posturing, where they have bizarre postures. And pacing rock back and forth, that's pretty self-explanatory. All right, you will need to know this slide. The positive symptoms of schizophrenia. When the antipsychotics were first developed, the first generation, or the typicals, were made to address the positive symptoms of schizophrenia. So the positive symptoms occur when there's an excess or distortion of normal functions. So in your content of thought, there's delusions, ideas of reference, grandiosity, paranoia. In your form of thought, looseness of association, neologisms, concrete thinking, perseveration. Your perception is done through your five senses. Sense of self is the echolalia, where you repeat words, echopraxia, where you repeat movement. Okay? You will need to know this slide. Negative symptoms are the deficit or the loss of normal functions. The atypical antipsychotics, or the second gen antipsychotics, were developed to address not only the positive, these symptoms, but also the negative symptoms as well. So their affect flattens, they get bland, they get apathetic, they get evolution where they don't move on their own free will, they get the ambivalence, they get the autism, the appearance deterioration, the anergia, okay, alogias where they don't speak in full sentences. You will notice that the majority of the negative symptoms begin with the letter A. Please don't get those letters confused, letter A's confused with any of the positive symptoms. All right? All right, so we're going to give antipsychotics, also known as neuroleptics. All right, they target positive symptoms. Okay, for the first gen, no observable effect on negative. Second gen, diminish positive and lessen the negative. Second gen works on dopamine, serotonin. All right, whereupon the conventional, the typicals, work on dopamine. All right, you will need to know this table. In the brain, mesolimbic system, that's where the positive signs and symptoms of schizophrenia emanate from. Mesocortical, dorsolateral, prefrontal cortex are the cognitive and negative signs and symptoms of schizophrenia. In the mesocortical, the ventromedial, prefrontal cortex, that's where the affective and negative signs and symptoms of schizophrenia come from. Nigrostriatal, that's where EPS or extrapyramidal symptoms or movement disorders come from. Tuberoinfundibular, that's where prolactin and diabetes type 2 come from. So, in speaking on prolactin and type 2 diabetes, the atypical antipsychotics are notorious for increasing prolactin, and they can also create diabetes type 2, but there's two of them that are specific for diabetes type 2. All right, these are the LAIs, the long-acting injectable. They are antipsychotics. They are given because oral medication non-compliance is an issue. It takes these medications about 36 hours to activate. They're good for about 2 weeks. Some of them can be given every month. And there's a new one that came out, I don't remember what it is, that can be given every 3 months. What you need to realize is that these medications tend to have a higher EPS effect, all right? These medications are extremely expensive. I believe Risperdal Consta is $1,745 per dose. And when you figure that the patient has to get 2 doses a month, that's a lot. The cheapest on this list are the Haldol-D, haloperidol, fluphenazine D. I believe they run both $500 per dose. The thing about these medications, they must be drawn up and change out the needle, and they must be given in large muscle mass and also with a clean, dry needle. A lot of these, like the Sustenna, the Consta, come in a kit. All right, so the advantages and disadvantages, you can monitor adherence because they have to come to the office every 2 weeks to get the shot done. There's no first pass metabolism. Plasma levels tend to stabilize. However, it takes them longer to get to that level. So injection site pain, irritation, and side effects are slower to disappear, and titration is much slower. So here are your typical or your second generation, first gen antipsychotics, all right? Haloperidol can be given as an IM to a patient who is agitated and out of control. There's an injection called a B52. The B stands for Benadryl, and usually that's 25 milligrams to 50 milligrams. The 5 is 5 milligrams of haloperidol, okay? And the 2 is 2 milligrams of lorazepam, and it's given to be able to stop patients when they're agitated. All right, Thorazine is an oldie but goodie, chlorpromazine. Mellaril or thioridazine, the thing you need to know about that, can cause QT prolongation. Do not give with SSRIs or beta blockers. These are the atypicals or the second gen antipsychotics. All right. There's a whole clozapine protocol that goes with clozaril or clozapine. The patient has to get a baseline CBC, and then after that, they do a weekly CBC. The pharmacy will not dispense the medication unless they have a current CBC on file. And the reason is the medication can cause agranulocytosis. Agranulocytosis mimics the flu. All right. If it gets severe enough, the patient is open to any type of infection, and it can lead to death. All right, ciprasidone You can give that IM if you have a patient who's agitated as well. The problem is there's issues with sudden cardiac death, so you really need to be very, very careful with it. All right, make sure you know these slides, okay? Any FYIs or precautions. So the meds block the dopamine receptors in the limbic system, okay? And that's how they are efficacious in managing the positive symptoms of schizophrenia. The meds relax the patient, they reduce fear, they make them more confident, more able to concentrate. Okay, and here's the thing about clozapine. All right, so the atypicals have fewer side effects. Um, the other thing that I need you to know is here the typical antipsychotics are further categorized as phenothiazines, thiazanthines, and butyrophenones. The phenothiazines and the thiazanthines block norepinephrine, which then causes sedative and hypotensive effects early in treatment. The butyrophenones only block dopamine, so please make sure that you remember this. So what are the side effects? Photosensitivity, gynecomastia, especially, I don't know if you've ever seen the commercials for the lawsuits related to risperidone, weight gain, agranulocytosis, EPS, right, which includes tardive dyskinesia and MS. All right, so make sure you assess the patient. You do movement, range of motion assessment to see whether or not they're test positive for any EPS. Education, tell the patient not to stop taking the drug abruptly. Use sunscreen because the medications make them more susceptible to the sun. All right, also make them more susceptible to any type of dehydration. Warn them about taking the meds during pregnancy. Every female of childbearing age should have a pregnancy test when they go into the hospital. Report monthly for labs, and don't forget about the clozapine. I think one of the biggest things too that I didn't put on here, tell them not to drink alcohol when they're taking the medication. Okay? All right. Hey, that's the end of that one. We're almost done. So let's take a look at response to illness. This is a short one. All right. Here's your lecture objectives. You know, I went through and I fixed this, and this slide is still missing. All right. So interpersonal factors, you know, how a person is able to cope with illness is going to depend a lot on what their values are and how they feel that they fit into society or their family unit. Whether or not they have social support, okay, family support, how efficacious are they by themselves? Are they independent? Are they able to drive? Are they able to cook and clean and take care of themselves in their home? How hardy are they personal wise? And how resilient are they? We're all born with a different level of resilience. Some of us are stronger than others. Some of us tend to be a little more fragile. And what is their strength and their spirituality? So, cultural factors, beliefs about the causes of illness. Some cultures believe that you're being punished because you're ill. All right. So, other things we need to look at, how do they communicate? What's their proxemics or physical distance rule? Do they have a social organization that can be supportive? What's their time orientation? You know, if someone says to me, well, I'll be back to see you in a couple of hours, what's a couple of hours to them as opposed to me? All right. Environmental control, we all want to be in control of how we live and what we do and when we do it. Biological variations, we know that there are biological differences. Um, I'm Asian, and I can tell you that a lot of Asians lack the enzyme that breaks down alcohol, so we tend to get intoxicated faster on a smaller amount of alcohol. All right, and their socioeconomic status and also their social class and their ability to be able to access care and the treatment possibly that they're going to need. So, culturally, as a nurse, you should learn about your patient's culture. And thank goodness for Google. Now we can look things up on the internet that before we had to maybe approach a patient and ask them about it. And, if the patient isn't willing to talk to you about it, you're kind of stuck. All right. But always, always keep in mind the patient's cultural practices when you're delivering their care. All right. And self awareness. Be caring, be empathetic. All right. Look at how you can promote the patient's well being spiritually and emotionally and mentally. Look at your own biases. All right. And remember that it isn't just a person in the bed, but they're a complex individual with unique needs. All right. And, I love the challenge of meeting new people because the more